Hi everyone, welcome to researchmd.com. We got a great presentation today. We're going to teach you all about Guillain-Barré syndrome, and all of our presentation is going to be 9 minutes, concise review. So we know the importance of saving time for you all. Okay. Again, my name is Pramil Cheriyath. I'm a program director, internal medicine, transitional residency. I teach medical students and medical residents, and I'm also director of research, assistant professor of medicine, two major medical schools. So what is our definition? Acute inflammatory immune mediated polyradicular neuropathy, presenting typically with the tingling and the progressive weakness and pain. Okay, that is our definition of Guillain-Barré syndrome. So these are the two scientists who discovered Guillain-Barré syndrome. If you look at, the first one is George Guillain, and the other one is Jean Alexander Barr. Okay, so the way I remember, like, looking at this picture, look at the hair of George Guillain or George Guillain. Okay, I mean, he got a nice haircut. I don't know, this 100 years ago, he had a nice haircut. Remember, hair, age. So in Guillain-Barré, you're going to have decreased age reflex. Remember that. That's like a good way to remember. Okay, epidemiology, you got the GBS incidence varies like anywhere 0.38 to 2.53 per 100,000. The median incidence been reported 1 to 1.10 per 100,000. Mortality range anywhere like 3 to 8%. All age can be affected, male predominant. Okay. So the causes, one cause always I remember, there's like this prodromal symptoms. You can have respiratory, GI, maybe immunogenic symptoms. So many causes are there. But always remember, Campylobacter jejuni causing diarrhea 4 weeks before is one of the predominant. You can have CMV virus, Epstein-Barr, Zika virus, influenza, all of that. But remember, Guillain-Barré. Okay, got a nice picture of Guillain-Barré. How does it play the molecular mimicry in between cis jejuni lipo-oligosaccharide and GM1 and GD1 has been found, and then attack the myelin sheath, then you can have GB syndrome. Pathogenesis, there are two phenotypes actually, purely demyelinating, and the other one is purely axonal. Okay. In the acute motor axonal neuropathy, you got antibodies binding to the GM1 or GD1, GD1A gangliocytes at the nodes of Ranvier and activate the myelin destroying complement. And the predominance of motor and axonal movement has led to designation of acute motor axonal neuropathy. Okay. Then you got the ataxia, which is sensory variant for patients presenting with ataxic sensory variant. The most commonly identified gangliocyte antigen target is GQ1B. Remember that. Okay. Now, there is another variant. There's so many variants also, but one variant you have to remember is Miller-Fisher variant. This is antibody against gangliocyte GQ1B. We're going to be making one presentation just for Miller-Fisher syndrome later on. So we got a nice picture. First one is the mainly demyelination, antibody attacking the myelin, and the next one is the mainly axonal loss. There is the GM1, and so you can attacking the axon, and you got the Miller-Fisher variant, which is actually antibodies against gangliocyte GQ1B. Okay. Now, variants of GB, we have this, always remember the Miller-Fisher syndrome. There's like locomotor weakness, ataxia, areflexia, and the prodromal syndromes, just like I said before. 1 to 4 weeks before the symptoms started, they could have respiratory infection, gastroenteritis, or even potentially immune stimulator. When we talk about vaccine, there's a lot of incidents about Johnson and Johnson COVID vaccine also kind of causing this. Okay. Now, what are the clinical presentation? First, the patient usually come with the hands and pricking pins and needle sensation in your fingers, sensory symptoms. Okay. Then kind of develop into the muscle weakness, both sides of the body, upper and lower, and then you got this respiratory and system compromise, paralysis, those kind of things can happen. So if you have a nice picture over here, so if you look at it 4 weeks ago, you have to look back, you'll find out 4 weeks ago patient had a prodromal infection or maybe vaccine, and the symptoms started, kind of stays kind of a little bit on the low side in the symptomatic stage for 2 weeks, and then you have after 2 weeks worsening of the symptom, end up in the ICU, and then mortality rate is around 5 to 8%. Okay, diagnosis mainly you get your history and physical. you get your diagnosis in this, okay? So National Institute of Neurological Disorders and Stroke, called NINS, they established a criteria. Let's look at the criteria. Progressive bilateral weakness of the arms and legs. Initially on legs may be involved, and absent or decreased tendon reflexes in affected limbs in some point in the clinical course. And the other feature that strongly support our diagnosis, the progressive phase lasts from days to 4 weeks, usually less than 2 weeks. Relative symmetry of symptoms and signs, and relatively mild sensory symptoms and signs. And you got cranial nerve involvement, especially bilateral facial palsy, and autonomic dysfunction, muscular or radicular back or limb pain, and increased protein level in the cerebrospinal fluid. And you got electrodiagnostic features. So blood test, you don't need to do any blood, but we do blood tests to rule out the other diseases. Okay, remember. And there are like antibody markers we can do. And the diagnostic value is measuring like levels of anti-ganglioside antibodies, limited and assay dependent. Okay, so you got antibodies to ganglioside, GM1, GD1A, and GQ1B anti-nuclear factor. In the anti-ganglioside antibodies, sensitivity is 42% and specificity to 76%. Okay. Now, then another important is the CSF analysis. You do a lumbar puncture. You're going to see this albuminocytological dissociation, which is a combination of elevated CSF level and a normal CSF count. Okay, and then you have electrodiagnostic studies are not required to diagnose GBS, but it'd be helpful in your diagnosis. You have specific tests for proximal nerve involvement seen in their absent H reflex. So if you have to remember, absent H reflexes can pick it up, in the initial early stages, and then recording of the F waves, abnormalities like dispersion or dropout in the F wave signal, and you can look at the sensitivity and specificity. It's pretty high in electrophysiological study, like sensitivity 81% and specificity is 94%. Okay. So again, we talk about the H reflex, a very important reflex going to be absent. It was named after Hoffman for original description. It's electrical counterpart of the stress reflex, which is elicited by mechanical tap. Group 1A sensory fibers constitute the efferent arc, which monosynaptically or oligosynaptically activate the alpha motor neuron that in turn generate the efferent arc of the reflex through the motor axons. Okay, so H reflex is very important. H reflex amplitude may be occasionally as high as the M amplitude, but it's often lower. Remember, H reflex can be absent in the initial stages. So MRI, again, not very helpful, but what will be the finding if you want to look at it? You just wanted to make sure you're ruling out the other causes like stroke and the spinal cord, and then presence of, you might see like the presence of nerve root enhancement of gadolinium enhanced MRI. It's a non-specific but sensitive feature of the, again, if it is sensitive but non-specific, it is the presence of nerve root enhancement. Okay. So there is like, so if a patient come in, you're always worried, are they going to take the worst stone or not? So what do you have to do? You can come with the risk assessment. We always talk about risk assessment. The one is the Erasmus Guillain-Barré syndrome respiratory insufficiency score. Okay, you do the score. There's some online calculator. You calculate then it can tell you the probability of patient is going into the ICU or on mechanical ventilation. Okay, we got a nice table over here. Days between onset of weakness, facial and bulbar weakness, and MRC sum score of the hospital admission. If the score is 0 to 2, you can kind of relax, low risk, right? But if it is the higher, greater than high risk of mechanical intubation. So anytime we do like a risk assessment, we can make a very good clinical judgment, be prepared for the future. Right, so in routine measurement in the patient, you have to look at the signs of respiratory muscle fatigue, like use of extremity muscles, counting during expiration, valve for capacity, inspiratory breath, vital capacity, and the negative inspiratory force. Remember the 20, 30, 40 rule, okay? So if a patient is deemed at risk of respiratory failure and if the vital capacity is less than 20 milligram per kg, the maximum inspiratory force is less than 30, or the maximum expiratory pressure is less than 40. Remember the 20, 30, 40 rule, okay? Muscle strength in the neck, arms, and the leg should be assessed. Monitor for swallowing or coughing difficulties. autonomic dysfunction and monitor the, I mean, some of these people have autonomic dysfunction like tachycardia, orthostatic hypotension. So what is the treatment? Mainly the treatment is a plasma exchange, remove the antibodies and possible inflammatory components. Also, you can have IVIG, the dose is given there. And thank you so much for watching. We'll be back with another presentation. Please subscribe to our channel.